So the Braden scale is an indication that your patient is either not at risk of skin breakdown or they're at high risk of skin breakdown.
Okay, I do know that the lower the number, the more at risk you are. Is that correct?
Um, yes, yes. The lower the I have to think about it. The lower the number, the more at risk you are. Yes, that's right. That's right. And so there are these different things right here that we are looking at on your patient. And this is your best nursing assessment. So you'll document this in the chart. Okay.
Okay.
So it goes off of sensory perception. Can they feel or can they not feel? Right. So patients like with diabetes, peripheral artery disease, they don't feel as well. Are they moist? Okay. And that's if the patient's sweating, you can't help that, you know? So, but you still want to document, hey, this is just a wet patient.
But it wouldn't that put them at risk?
Yes. So that's why it's concluded as part of what we're scoring.
Okay.
Okay. And then you've got activities. So are they able to move? Okay, this isn't mobility because that's the next one. So activity, you can see they look like do they can they get up and get into the chair, right? Can they at least are they able to ambulate? If they're able to ambulate, okay, then we just mark like, hey, they can do activity.
Yeah.
And then the next one is mobility. Do they have any limitations on their mobility? So if they don't and they ambulate, then that's good. But what if they are in traction, like where they're
Or
stuck
just
in the
bedbound
bed or
and they were
bed
so
bound?
So
Exactly. So that would score lower. Okay.
Yeah.
And then you're looking at their nutrition. So are they eating by mouth? They eat full meals, everything's fine, or they barely eat anything, or maybe we have to replace some of their feedings with enteral feeds, or, so it looks at their nutrition. And then the last one is friction and shear. That's rubbing, right?
Yeah.
So friction and shear is a big part of skin integrity.
Yeah, they were talking about that a lot. So
Mhm.
so shear is like if somebody's like sitting up and they're like sliding.
If they're sliding, and the other time where we see shear, and this is very avoidable and it's probably going to be on your test, when you're lifting a patient in bed, especially an older adult patient, right? Because if you try to lift them and just rub them across the sheets, the whole back skin can tear off, right? So you have to use a draw sheet or a lift sheet every single time, which requires two people. Okay.
Yeah.
I've never actually seen this done because my grandma's in a nursing home and they always just pull her up, which is painful, right? What they'll do is they'll get underneath their armpits and just pull them up in bed. That could dislocate their shoulder. It can cause armpit injuries and it will shear the whole back, right? Which is why if you're moving a patient, you're supposed to use the draw sheet. So one person on one side, one person on the other side. You lift the draw sheet together with the patient on it, and then you move them up and then you set it down so that there's no shearing. Okay. And never lift anybody by the armpits. It's super painful and it causes shearing too.
Okay. Could do that.
Yes, I've seen them do it lots of times. Yeah. Okay. So this is the risk scale. Okay. So the higher the number, the less at risk they are. Okay.
Yeah.
So you can see it down here. There's no risk. There's mild, moderate, high, or severe. And then you will advocate for your patient based off the score. So let's say you have a patient that's in the ICU. They are intubated. They were in a terrible car accident. They're going to be intubated for weeks, right? They're not moving. They're totally immobile. Their nutrition's not that great. They're probably have a lot of moisture, they're sweating, they're in pain, whatever. I'm going to advocate for different devices for my patients, right? Like a pressure ulcer mattress, okay? A rotating bed. They have those in the ICU, okay? Because if a patient's in traction, you can't really move much the patient, or if they're broken something, you can't turn them, but the bed can turn, right? And just, it will kind of just, even the slight shifts can help.
Most hospitals and things have
Even UTB has it, so yes. I would say yes.
Okay.
Yeah. You can advocate in neonates. We use something called a Z flow. It's like a little, how do I explain it? Like a little beanbag pillow for them that completely like accommodates to their head. Right. So there's different things you can advocate saying like, hey, my patient is at high risk of pressure ulcers. We need to get a couple things. Right. So that's a Braden scale. We understand it. So we're going to talk about basics of skin assessment. Okay. So what your responsibility is as the nurse. So you do have to document all of these wounds, right?
Yes.
Okay. So you need to know the description and how to describe them, right?
Yeah.
So an incision is just any kind of cuts, right? A contusion is like a bruise.
That's intentional.
It could be intentional or it could be unintentional, right?
Okay.
An incision just means that there was some kind of cut there, right? Now, it probably, if it was unintentional, I would more document it as a laceration, right? But it
But it could be.
yeah. Sure, either one. And then a contusion is a bruise because of trauma, like something hit you really hard, but there's no opening in the skin. It's a bruise underneath. Yeah, yeah. But you can see like one spot where it did that. Right. Okay. An abrasion. No, the skin isn't broken. Abrasion is the scraping or the rubbing. So that's like a kid falls off his bike and scrapes up. Exactly. Chemical is anything like a chemical burn, right? And you can see that we see that a lot in burns. A laceration is some kind of tear, but it's also a cut, right? So it's a cut that kind of tore. So like if you have a baby, right? And you tear down there, that's a vaginal laceration. So you can intentionally make a laceration, like if they did an episiotomy, they made an incision and it lacerated the skin, right? Or it can be, where it just tears open on its own, but you can still see a pretty linear
So you
laceration.
can actually make laceration.
Yes.
Okay, 'cause I was just thinking lacerations would just like accidental.
Oh, no, it doesn't have to be accidental, right? It's a laceration I would describe more as a tearing. If you are making a cut in surgery, you would more call it an incision because you're not tearing your skin. You're straight up cutting your skin. Yes. All right. An avulsion is where something has been torn from a structure. Okay. Like your toes coming off. Oh. Or like it doesn't have to be the whole toe. Like it'd be part of the meat has been pulled off of it, right? Or you get a big chunk of skin that came out. Okay. So something has been torn from its actual structure. Okay. And then
My thumb or something.
was like if you got a big chunk off. I mean, if the whole thing came off, I wouldn't call that an avulsion. Right. That would be your thumb has been amputated. Okay. Yeah, but if something has been torn from where it originally was, like a tear from where it was, then we call it an avulsion. And then any kind of thermal would be a heat or a cold injury. So it would be a thermal burn. We see that a lot when patients don't feel as well on their extremities, like our diabetic peripheral artery disease, and they left something on for too long, like maybe they put a cold pack on, they don't feel it. So that's why patients with diabetes are not supposed to have any extremes of heat or cold on their legs. So they can't get into hot tubs, they can't do hot baths, they shouldn't be doing ice or heat on their legs where they don't feel as well. Okay. All right. Now, this is what we were talking about earlier, right here, these types of drainage. These are your exudates. So purulent is pus. We do not document a wound as pussy because when you read it, it does not look like the word pussy. It looks like a very bad word. And you do not want to put that in the documentation because then the doctors will be looking at a very different place. So that is not a word, okay? If there is yep. I have had to tell my students this every single semester, even when I was an instructor, because I was, yeah. No, for sure, for sure. So we say it is a purulent discharge, okay? Because pus is something like we made up, like that's a slang word, right? So purulent discharge. And then sanguineous that's blood. Yes. Yeah. And you got pee. There you go. Oh, be careful with pee in the ear. No, I'm just kidding. I'm just kidding. Okay. And then serosanguinous, because okay, so sanguineous is clear.
Sanguineous.
Oh, sorry, I messed that up. Ooh, I messed this up. I'm glad I said something. No, the bottom one, I need to redo this. This word right here should say serous. I just wasn't paying attention, I guess.
Wait, where?
Change the one that's clear,
Yeah.
okay, to serous.
Oh,
Serous. Cross that out. I gotta fix that. I wasn't paying attention. All right, so serous is clear, and sanguineous is bloody. So serosanguinous, when you put red and basically clear, right, or white together, you're gonna get pink, right?
Yes.
Okay. You expect someone?
Was that answer?
Yeah.
Oh.
I don't know. Squeeze here. Hold on.
What is it?
Oh. Okay. Moving on. What?
Pink something.
This is my doing. I'm not even in nursing school. Okay, let me get this back on. Hold on.
For facility. At.
Mhm.
I mean, it's the degree of. I mean, it's to determine how severe the wound is.
No, the Braden scale tells us how at risk they are. These are patients that don't even have wounds. Okay. So the Braden scale, and there's a spot in every chart that you have to document this every single shift that you performed a Braden scale. It basically tells you how at risk your patient is to tell you how meticulous you need to be doing skincare. Okay. And we'll talk more about it in just a second.
Okay.
All right. In the older adults, okay, you know that they have very thin skin. They don't have as much sensation. So their skin can get injured. Very likely for them to tear. So much so that, like, when you are doing an IV, you know, we start an IV, we usually pull their skin like this. Okay. In older adults, if you pull like this, it can shear the entire top layer of the skin. So you can't do that. They're also very sensitive to tapes and stuff like that. So have they talked to you about duoderm, or you know what duoderm is?
He said something about tapes that they don't stick.
Yeah.
Is
So,
that
well, duoderm is like a fake skin. And so it is sticky, but it stays on all the time. So you put, it looks like a little patch of skin like this. And then you put the tape and you tape whatever you need to tape to the duoderm. And then you just pull off the tape off of the duoderm so it doesn't actually pull off of their face.
so
Because
pull the tape
off the duoderm, it's on the fake skin.
Okay.
It's not actually
But
pulling
then
off their
that means
skin.
the fake skin
You keep
is-
it there for as long as they're in the hospital. I mean, it could be on there for weeks or months at a time.
Oh.
Yeah.
So are they like big?
No, they're small. I can show you what they look like. And then you kind of shape it towards whatever shape that you need. You can cut it and stuff to shape it. Like if you're putting on oxygen, I would want one that goes across right here, right? So that way I could tape the oxygen right there. If they have an NG tube, I'd probably put one here. So you can put them in different places and make them into different shapes. Yes, to protect the skin. We use it in neonates. It's always in the NICU. And then we use it for older adults. Okay. Duoderm. Mm-hmm. I'll kind of show you what that looks like. Let me see if I can find it.
She said something, but I don't choose that word and not. But is it basically duoderm? What would you? Is it like covering without tape?
It's like a more permanent cover, but it's meant to be fake skin for you. So that we tape it to the duoderm. Now, it's usually a much darker color than this, but this kind of gives you an idea. The skin goes, I mean, it's a fake skin. It's very like smooth. I don't, it feels like skin. Okay.
Oh.
And so you can put it on here and then you'll tape stuff to that duoderm and the duoderm stays in place all the time. So then when you have to pull up the tape,
doesn't go on the skin though.
nope, it goes on the duoderm
And
it'll
stay
stay.
in place.
Mhm. Yep. Because it's fake skin. It's just like taping it to someone's skin, but it's just fake skin.
Oh.
Yeah. So that works really well. And then they have a decrease of sebaceous and sweat glands, so they're not able to get rid of waste as well, right? And then their healing time, of course, is going to be increased. Okay. All right. So after this, let's talk about the Braden scale. Exudate. This is gross. Anything that leaks from a wound, that's an exudate. It's all third space fluid. It's just what the fluid looks like. That's all it is. So your body said, something is wrong. And it's vasodilated and increased capillary permeability, and it leaked into the third space. Now, if it leaked really hard and your blood was going really hard, it's going to be bloody third space fluid, right? If it brought a lot of white blood cells because there was a lot of like infection or something, that's going to look more like pus, right? If it had third space fluid plus blood, it's going to look kind of pink. So that's what these are, is basically what's coming out of you. What type of third space fluid is it will tell me kind of what's going on with the patient. Okay. And I know this is gonna be super gross, but this is the best way that I can explain it. All right. You ever had like a giant pimple and you like have to go somewhere and you're like, oh my God, I cannot go out with this big old giant monster and I have to pop it. Y'all all know what I'm talking about. So don't act like, oh my God, I never get that. All right. So when you first pop it, what happens? What comes out? Pus. That is called purulent fluid. And one of the best pieces of advice I can ever give you, look at me. This is very important. Do not ever, ever document that the wound is pussy. Because when you read it on a chart, it says that the patient has discharge. Yeah. That's a very different ballgame. The P word. Oh, there is no such word as pussy. We made that up. And if you actually write it out, it looks very bad. Yeah. And you'll get in very much trouble for putting that in EMR. Okay, that's not a word. The word for lots of pus is purulent. Are we clear? So nobody's going to write the P word on their charts, right? Okay. So you pop a pimple and a bunch of pus comes out. That is purulent. Okay. As you keep squeezing it, what happens? It starts bleeding. And what kind of discharge is that? What's that called? The bloody one. Sanguinous. It's blood, right? It's red. It's because there's a lot of, we vasodilated and brought a lot of blood to this area. Okay. You keep squeezing it. What does it come out? It's going to it turns pink after the red, right? That's because there's some like clear fluid and then there's some blood and that mixes together and make pink. Okay. Keep squeezing. What comes out? Eventually, it'll just be clear
Clear.
fluid. Yeah, it's clear. You're like, oh, I got this. I know. It's clear fluid. That is called serous fluid. Do you see what I mean? So all these are exudates or different things that are coming out of either wounds or your body in some kind of way, depending on what third space fluid is coming out. So right down here, I told y'all what is the name of it, what is coming out, okay, what color it is, and kind of why it's there. Do we understand that? There's two more. If you look up at the top, fibrinous and membranous. So fibrinous is usually very like thin, and it's if they say strands, it's fibrin. Fibrin is something that comes out when it thinks that there's something wrong, but it usually helps with some kind of clot or something. But in this case, we see it a lot in like strep throat. Have you ever seen like that kind of nasty coating sort of on the back of your throat when you have strep? Do you know what I'm talking about?
Yeah.
It's pretty gross. That's what we call fibrinous. And then there's membranous. Have you ever had a cold sore? Okay. You know, it has that yellow green stuff on it and you can like wipe it, like sloughs off. Okay. Let me think of another example. I don't know. Oh no.
Like a scab?
No, because it's not hard. It's have you ever had pink eye?
Yes.
Okay. You know that stuff that kind of just sloughs off?
Oh, yeah.
Okay. It's usually some type of membranous something. You ever had like not a cold sore, because those are usually here, a canker sore? You know what I'm talking about, like inside your lip?
I know what you're talking about.
We are the healthiest people alive, or damn, what is it? Okay. It's something like you can actually just like rub it off. We see this a lot in like little boys when they get circumcised, like it forms a membrane over the top of the penis because you cut it off. So obviously there's going to be some third space fluid because your body's gonna be like, you cut my pee-pee. You know what I mean? So membranous it is meant to be healing tissue. It's not infection, but you could actually like wipe it off. Okay. And it would just be like raw underneath. Okay. Do we understand exudates?
So just a quick question. So why it turned from, say, green, reddish to white? Is that this is a process of like the blood is not there anymore?
Yeah. It's not quite so much like blood flow anymore.
Oh.
Yep. That's right. Okay. So this is pressure ulcer staging. So they will ask you to stage these. They won't give you a picture probably, but they will explain it and then you're going to have to stage it. Okay. But there is more than just 4 because there is suspected deep tissue injury and then there's also unstageable. Okay. So stage 1, you need probably a keyword for each of this. It's just redness, right?
Right. Yeah.
So nothing is broken. It is non-blanchable. Do you know what blanchable means?
Like it means if it's not blanchable,
It's going to stay red. So when you push on it, it just stays. So it's intact skin. It's just starting to be red. We want to catch them at that point. I mean, we want to prevent them, of course.
Yeah.
But if you catch them at this point, there's not really a risk of infection or anything like that because the skin is still intact. That's the only one with the skin is still intact.
Yeah. Stay peptide. Right. Yeah.
And then we go into we're going to stage 2.
Oh, your glasses?
Yeah, I did it. Oh, thank you. I'm blind today. My eyes are dry.
That's what I was doing with my paintings.
Really?
Yeah.
Okay. So in stage 2, we're going to go into partial thickness. You can see the skin is broken and you can see the next layer of skin underneath, right?
Yeah.
So, but you can still see a red pink wound bed, which is good because we want it to be red. It doesn't mean that it is infected. That means that there is blood flow, which I'm happy with, right?
Yes.
Okay. It can also present as an intact or open ruptured serum filled blister. So if there's a blister on the skin, okay, because sometimes it hasn't completely opened, right? It's third space fluid, right? Because your body knows something is wrong. It's the inflammatory process. It just didn't break through the skin. That's what a blister is. But remember, you're not supposed to pop blisters because once you pop it, now the skin is open, right? So stage 2 could either be, it's very shallow, it is open, but it has broken through the skin, or it could be either a fluid filled blister or a popped blister.
So it could be a blister too.
Because it is broken skin underneath, right? I mean, it's just like a teeny tiny little membrane, right? All right. Then you go into stage 3, that is considered a full thickness, okay? It has gone through to the subcutaneous fat, okay? It's gone through to the fat layer, okay? At this stage is where we might see undermining and the tunneling, okay? So undermining is kind of the start of it where it's starting to get a hole in the tunnels, like the whole shebang underneath. And sometimes we'll even take like because the tunneling doesn't necessarily go in a straight line. So you may not be able to do that Q-tip thing where you get, right? We may take a catheter, and this is gross, but like, cause a catheter is bendy, not like
yeah, it's not flat.
yes, because it'll kind of follow through and then we can see how deep it actually is.
So that what they typically do in stage
You can do
3?
that. If you see that there is a hole or you think that there is undermining or tunneling, I haven't seen that very often.
Oh, no.
It's not often that it tunnels, but it can. Okay. And then stage 4, this is the, yes, this goes all the way through where you can either see bone, you can see tendon, or you can see muscle. You may see slough, and slough is like the stuff you could actually wipe off, but it's not pus. Yes. It's an exudate. It is yellowish. And sometimes, I mean, it depends. You really have to determine, is it granulation tissue, right? Is it pus? Is it healing tissue? What is it? Because I don't want to wipe off, right, granulation tissue or healing tissue, but I also don't want to leave junky, right? So most of the time we'll kind of let it be unless you really think it is pus, right? Or purulent discharge. Okay. But you'd have to ask the physician, like, what do you want to do with this? And they'll usually tell you, right? But most of the time we'll just leave it intact because pus doesn't usually present like that. Yeah, this is actually it right here. All that yellow stuff.
Oh, this right here is slough.
The yellow stuff.
Oh,
Yeah.
okay,
Yeah.
okay.
And then Eschar is the black or the starting to get necrotic tissue. It's practically dead. Yes. It's necrotic tissue that we're going to have to get rid of. Okay. And so you need to determine at stage 4. A lot of times they'll go into surgery to figure out what they need to do with it, right? Because they may need to cut off some of the necrotic tissue. They may need to get some of that slough off, and you don't want to be digging around near someone's bone. The other thing you got to think of, sometimes it doesn't even hurt anymore because it's not burned through, but it's gone through the nerve endings. And so they don't really feel it. Yeah. And in stage 4 too, you have to worry about osteomyelitis, which is infection of the bone, because now you've got this. Yes, the bone exposed. Okay. And then suspected deep tissue injury. So usually you'll go off of color. If it's a purple color or maroon color, okay. Basically, this is a very.
Is it open?
It is open, but I also can't tell what's going on underneath. Okay. Because remember, you can have tunneling, you can have undermining, you can have all of that, right? So if you look at it and it looks very discolored, if it didn't hurt the patient, this is gross, okay, but this is the way that I'm explaining it to you. If it knew it wasn't going to hurt the patient, you could just squish your hand and it would just go into that ulcer because you don't know what's underneath, right? So if it's a purplish or a maroon color, that tells me there's a lot of blood flow collecting here, which tells me I don't know what's underneath because I can't see it with my eyes. So it's squishy, it's boggy because there's stuff going underneath there that I don't know, but that's why it's called suspected because I can't see it with my eyes. I can just, it's called suspected deep tissue injury because I'm looking at it and I'm like, this is boggy. It's very warm. I think there's something underneath there that I can't see. You need to image it and see if there's anything we can see. Okay. And if not, and they really think there's something underneath there, it's not healing. They may need to go into surgery to suspect like there may need to be a debridement or may need to go like really in there and find out what's up in there. Yes. And then unstageable, it's still full thickness, okay, but it's in different stages. So full thickness goes all the way down, right? It's going to go down to like either fat layer or muscle or whatever. No, unstageable just means I can't stage because it's in multiple different stages at one time. Okay. So I may be able to, let's say it's a sacrum, right? Part of it is just red. Okay. And then part of it, I can see all the way down to their vertebrae, but there's also part of it where it just has like a blister. So it's in so many different stages. I would call that unstageable because it's not just one stage. There was probably multiple issues at one spot. Mm-mm. No, it just is like, this one kind of looks like 2 and this part right here looks like 4. And so I can't stage it. Yes, if it's a combination of different stages, right? And that could be at multiple levels of healing, right? Or that they could have been laying in different, sometimes I've seen where people have been laying on crumpled sheets. And so where those folds are is a different layer than where the sheet was flat, right? So unstageable just means like, I don't know because it looks like multiple stages at one time.
Oh,
Okay.
okay.
Did these make sense? Okay. Yeah, that's a bad one. All right. So pressure ulcer cheat sheet. So this is all the basics of what you need to know about pressure ulcers. Okay. So we know that these are from prolonged pressure, usually from our immobile patients. Immobility is the #1 risk factor. Okay. But even if a patient can't ambulate, we can still move them. There's lots that we can do to move them.
So that just be like,
yeah, every 2 hours you're supposed to turn them, or even if you can get them sitting up at the side of the bed, or even if you can get them up to a chair that's right next to the bed, that's moving and putting pressure. We want to move our patients because when a patient is still, their lungs are still, they're at risk of pneumonia, right? Their skin is still and it pulls to the back because they're laying back, right? So that puts them sitting in edema, pressure ulcers, right? Their gut doesn't move because they don't move. Constipation, major bowel issues. The consequences of immobility are huge. So however you can move your patient, move your patient. Okay. So places that are most affected is sacrum and coccyx, of course, because you're laying on it to touch your butt, right? Trochanter, which is the hips because they're turned on one side, right? And they just lay there.
Okay. Turned on one side.
Yeah, because people will come in, and I've seen this with my grandma. They'll come in and turn her, but then they don't ever come in and turn her back. So she may be sitting on this side for hours and hours at a time, right? You got to rotate, otherwise you're going to put pressure on one part. Every 2 hours. Remember TCDB Q2, turn, cough, deep breathe every 2 hours. That is the basics of nursing care that you could give to every single one of your patients. Turn, cough, and deep breathe. Okay, so we're preventing pneumonia, we're preventing pressure ulcers, right? All right, and then the calcaneus, which is, the heel. Those are notorious too because they're laying there, right? With their legs straight and flat, which we don't want either. Okay. Sometimes you can elevate them. You can also there's different boots that you can put on that are pressure relief. There's wedges. You can put pillows between their legs. I mean, there's a bunch of stuff that you could do, right? All right, so let's talk about risk factors for pressure ulcers. A lot of these are going to sound familiar because they're also risk factors for developing wounds. Okay. Like immobility, diaphoresis, we talked about, incontinence, we talked about. That's diarrhea or urine, right? Any chronic illnesses, that was the same. Elderly, malnutrition, all of those we already said were risks for skin breakdown. That is Glasgow Coma Scale. So that's the basic neuro assessment that you do on your patient, basically every single patient. You probably haven't done neuro yet. So Glasgow Coma Scale, like if you're watching TV or something and they say GCS is 15 or whatever. So the maximum score for GCS is 15. The minimum score is 3. Anything under 15 is considered altered mental status. Okay. If their score is below 8, they're so altered mental status that we have to intubate because they don't even have enough going on in their brain to breathe and to do those natural functions. Okay. So GCS is the very basics. You look at eye-opening response. Okay. So when you go into a room, and they hear me, do their eyes open spontaneously or not, right? Or they just like this, okay? The second one is the best verbal response. What's your name? Where are you at? Can they respond back to you verbally? And then the last one is your best motor response. Squeeze my hand, Mr. Jones, squeeze my hand. And either they can't, or they don't respond. Yeah. Or dead. That's when we first come out to a scene, we do a GCS, right? To see where is their neuro status. Yeah. So if they have lower GCS, obviously they're going to be at risk because they're not moving. Okay. Any spinal or brain injury, because that will cause them to have no sensation below the level of injury. If they can't feel it, they don't know something's hurting them. If they have a fracture, which means they're in a cast, and or they're in traction because they cannot move at all in traction, right? You can't even turn them. So yeah, it's bad. Okay. All right. So when we are measuring, this is just a reminder, when we're measuring pressure ulcers, we do the length, the width, the depth. Is there tunneling? And then there's 4 stages, which I'll cover more in a minute. There's 4 stages just for pressure ulcers. Okay. And then you look and see if there's undermining or a sinus tract, which basically means we're going to start to tunnel. Yeah. It's all basically describing the same thing. Okay.
Ask us questions where it's tunneling versus sinus tract.
I don't think so. I think it's just kind of more the word that we use to describe what. So in wound care, we more say it's called tunneling. In a pressure ulcer, we more so say there's undermining. And a sinus tract just means that there's a hole and you follow through the hole. Right? So a tract, it's all basically saying the same thing. It's all basically saying the same thing. Your body's just working its way through trying to figure out, hey, let's dig a tunnel and figure out how to get out of here, So it's all basically saying the same thing. And then friction and shear, big deal. Make sure that you do not do that. Okay. All right. So let's go right here. We're going to go to what we need to assess for pressure ulcers. So for every single patient, they need a Braden scale every single day in the chart documented. Okay. You need to assess every single day their mobility and their every day what you think they can do and set a goal of that. Okay. So you may have had a patient where they ordered bed rest. And then you realize I think this patient could probably get up. I'd call the doctor and be like, can we try to get him up today? You don't have to just do what they tell you to do. We got to advocate for our patient if I think he can get up, maybe if I'm trying to move him from bed to chair and he was able to bear weight on his feet and he kind of got up and did it himself, I'd be like, hello, and get a call for a different order. You need to assess their nutrition status because you may need to supplement with some different vitamins or minerals, right? Is there moisture? Are they incontinent? Does a pressure ulcer hurt? What's the color, right? I need to know if it's necrotic. 'Cause if it's necrotic, I need to call the doctor and get them to come out and debride it, right? If there's a drainage, odor, granulation tissue, or epithelialization is where the skin is starting to grow back, which is yeah, but we want that to happen, right? Right. So you need to document, and that's basically what kind of stage was it, and then what stage of healing are we in, right? Because we did the different stages of wound healing, right? So you're going to document the stage of the pressure ulcer and then what stage of healing that it's in. So you may get in report like, hey, this was a stage 4 pressure ulcer. And then you go to look at it and you're like, actually, it's got granulation tissue. So it was a stage 4, but now we're in. Oh, yeah, you look down and see like their vertebrae. Yeah, those are bad. Those are usually we see on the syndrome or the coccyx. Yeah. Which we'll talk about each stage because you're going to be tested on this for sure. All right. Here's your Braden scale interpretation, right? What the scores mean. Okay. So at 19 to 23, no risk, yada, yada. All right. So how do you prevent pressure ulcers that they ask you? Usually they'll ask you some kind of select all apply. How do we prevent pressure ulcers in our patient? Right. Because the best way to treat them is to not have one in the first place. Right. They'll ask you those kind of questions a lot. Like when you do urinary, they'll say, what's the best way to prevent a catheter associated UTI? Don't put in Foley. I mean, that's the best way, right? That's the best way. Yeah. So they'll just watch out for stuff like that. All right. So best way, how do we prevent? Keep their skin clean and dry. Turn them every 2. We know that that's the basics of nursing. Ambulate them. As soon as they're able to ambulate, move on. Okay. Even if it's just to a bedside commode or a bedside chair, right? Use a pressure relief mattress. It's kind of like a bubble wrap mattress. It like conforms to the patient. Yeah, it's like that. An air mattress. Yeah, kind of like that. It looks and kind of feels like bubble wrap, so it does conform exactly to the patient. I don't know if you've ever laid in a hospital bed; those do not conform to the patient. They're flat and they feel horrible. Yeah. A hip wedge. So that is it is a triangle that goes. It's foam and it goes underneath their hips. You can turn them to one side, put the foam wedge underneath, and then come back 2 hours later and turn them to the other side. Because if you just turn them to the side, I mean, by gravity, they're gonna go back over. So putting the wedge in will help keep them on their side. Okay. Got it. And then footboards are really good. Yeah, it's a wedge. Yeah. Okay. And then footboards are like it's like little boots that they'll put on them and they keep their legs out like this. And it's padded on the back. So it's actually, they wear the boot. I'll show you what it looks like. They usually use it like post-stroke patients because in post-stroke patients, their foot will drop like this naturally because they're weak on the side and it'll get stuck like that. Yeah. So it'll be very difficult for them to ambulate, which we need to ambulate, right? Let me show you. Oh my gosh, Google probably thinks I have like every ailment in the books. I've Googled like every disease and like, you know how when you Google something, your phone is like connected to all your devices? Yeah. And so I guess it thinks that I have like diabetes and pressure ulcers, like, because it always sends me stuff on struggling from diabetes, like, I was just learning about it. Okay. Let's see. Trying to find there's all different kinds. I'm trying to find the most common one you might see in the hospital. No, these aren't them. Hold up.
Microphone. Yes.
Okay, this one's kind of good. Okay, so they may put them in boots like this. So it's like all foamed around and it doesn't put any pressure on the heel. That's all padded. Right. Yeah. So they can just put them in those and they don't hurt you or anything. But these would be like our immobile patients because you obviously can't ambulate with those. Yeah. Right. But I've seen them. They're in my grandma's bed. They let her wear those because, she's in bed all the time and you can get really bad ulcers on the back of the heel. Yes. Yeah. All right. Let's see. Perform range of motion exercises every shift. And you know that there's 2 different types of range of motion. There's active and passive. We always want it to be active because that's the patient performing those, but sometimes they're too weak or they can't. And so we will perform it for them. That's called passive. So we will, move their arms and move their legs and things like that if they're not able to perform that. Is me doing it, right? We do it. And then active is them actively moving their own extremities. Okay. All right. Frequent perineal care. That is to prevent ulcers like in the perineal. We're still on preventing. And I've seen pressure ulcers like between the vagina and the rectum because nobody spreads that open and looks, but that's a place you can get them. Head of bed is around 30 degrees. That's probably the best because if they're up too high, that puts a lot of pressure on their sacrum, right? So we want them sitting back and relaxed. Yeah. No hot water on their skin, right? Because that's going to burn. Do not massage the bony prominences. They used to tell you to do that, but that puts more pressure on it when you massage them, right? So you pad them, but you don't massage them. Okay. Do not lift by the axilla. I told you that. Don't lift by the armpits. It hurts them very badly. And do not scrub their skin. You never pick. In nursing school, you're never going to pick to vigorously do anything. If they ever describe it as vigorously, like vigorously scrub their skin to prevent infection, it'll sound nice. And don't let them trick you. Okay. But yes, we don't do anything vigorously. We softly or gently or nicely do something. The microfoam dressing is very nice for pressure ulcers. It is stretchy. Okay. Let me show you what it looks like.
That's for the microphone. Is for pressure ulcers.
It's a microfoam surgical tape. Do I use it for anything else?
Mostly just pressure ulcers.
Let me think what else I've used it for. Yeah, mostly I would say it's ulcers.
Okay.
But it looks like it comes in a roll that looks like this. It's foam. Okay.
foam,
Yeah, it's actual foam. Very thick. Yes, it's very thick. I'm trying to find it on a patient. See if I can find it on a patient. Or here's what the pad looks like if they flip it up so you can see how thick it is.
So it is thick.
It is thick. It's very cushy, right? Because regular tape does not stretch, right? It's very abrasive to the skin. But the microfoam does have a little stretch to it. It is nice and soft, and it kind of conforms to the patient. It's sticky.
Oh, it is.
Yeah, so you would pack the dressing or put whatever dressing you have, and then secure it with the tape because this is microfiber tape. No, the dressing would be like the actual like the gauze or whatever, or like the dressing that you're putting on it, and then you would tape that, right? Okay. No, the tape is to last thing. It's the very last thing because it's also waterproof, right? So this is tape, so that would be over anything. So you have a wound, you would pack it with gauze, and then you put the tape over it to keep everything together. Does that make sense? Okay. Yeah, that's okay. All right, so that's microfoam dressing, and then make sure you use a draw sheet to lift and move the patient. What about that? Okay, easy enough.